Vokanage-Harada disease is defined as a bilateral granulomatous panuveitis with or without extraocular manifestations like headache, tinnitus, neck stiffness, hearing loss, and integumentary findings affecting young adults. There are three clinical entities, namely complete VKH, incomplete VKH, and probable VKH. All three categories of the disease have absolute requirements of bilateral eye disease, absence of history of trauma, no clinical or laboratory evidence suggestive of another uveitic cause. So, a 36-year-old female presented with complaints of eye pain and blurring of vision since one day. Uncorrected visual acuity in both eyes was 6 by 12, not improving by pinhole, and a near vision of 6 by 18 on reduced Snellen. The refraction showed hyperopic error. Color vision was within normal limits, and on slit lamp examination, both eyes showed anterior segment which was within normal limits. The retina showed multiple pockets of subretinal fluid over the posterior pole and peripapillary SRF. This is a fundus photograph of both eyes showing multiple pockets of subretinal fluid. This is an autofluorescence of the same showing areas of hypoautofluorescence corresponding to the pockets of subretinal fluid. The OCT image showed bacillary layer detachment and multiple septae forming compartments or pockets of the subretinal fluid. The FFA showed multiple pinpoint areas of hyperfluorescence which corresponded to the pockets of subretinal fluid along with disc staining, and a diagnosis of probable VKH disease was made. Patient was treated with 1 gram of IVMP per day for 3 consecutive days, after which she was shifted to oral corticosteroids which were tapered weekly, and adjuvant treatment was given. On 1 month follow-up, the best corrected visual acuity improved to 6/9 parts with near vision of N8 in the right eye, and left eye was normal. On slit lamp examination, retina showed few hypopigmented spots at the macula with peripapillary SRF. The OCT at 1 month showed resolution with slight SRF in the right eye. Left eye was normal. On subsequent follow-ups, patient was maintained on azathioprine and was monitored for CBC, LFT, and RFT, and was asked to come for follow-up every 3 monthly. So VKH is an important cause of bilateral loss of vision and has a good visual prognosis if aggressive treatment is initiated during early stages. The most common finding in acute cases is serous retinal detachment followed by disc edema, and in chronic cases, depigmented fundus. A study showed that VKH occurs less frequently in India than in Japan and United States. Extraocular signs are far less common in Indian population, and visual prognosis is good in patients presenting within 1 month of onset of symptoms. In a retrospective analysis by Lodi et al. Of 32 patients of VKH in South India, reported it to be more common in females, and showed that posterior uveitis is the most common initial manifestation. Initial aggressive treatment with IVMP and immunosuppressives gives a good visual outcome without recurrences. So VKH is a bilateral condition commonly seen in females in the 3rd or 4th decade, which can cause vision impairment. It is usually managed with systemic corticosteroids, and the patient can be maintained on immunomodulatory therapy. The differential diagnosis we considered was bilateral CSCR, which was ruled out with help of OCT and FFA, and sympathetic ophthalmitis, for which we have to rule out history of trauma. Thank you.
I think it's a very important topic which you covered, VKH, because in this I'd like to ask you, did you rule out tuberculosis in every way?
Yes, ma'am.
So you didn't mention what all investigations you
We
did.
had done blood investigations like CBC, blood investigations like CBC, ESR, CRP, MAN2, chest X-ray, and TB Gold.
Just chest X-ray would not pick actually. You have to go in for HRCT
Yeah, right.
and
That
ultrasound
wasn't
abdomen,
done, yeah.
because you're giving very high steroids, and we've also had cases like this,
Yes.
and they have turned out to be tuberculosis so common in India because the systemic features, as you said, are not present in India as much. So it is also a very long treatment which need to be done. So tuberculosis has to be really ruled out. Thank you.